Invite Professor Dr. Shanti Madam, the Professor of Ophthalmology, CMC Hospital, Coimbatore, to give the talk.
Good afternoon, everybody. Thank you, sir. Thank you so much for this topic. Thank you, IMA, President, sir, Chairman, Organ Donation. So the topic is about recent advances in corneal donation or eye donation. So the following like organs are being transplanted. And so we know that there is a live transplant and a transplant from deceased patients. So the trouble we see in eye donation is after the pandemic, there is a large drop in both eye donation and number of surgeries of cornea. So there is a drop of 63% in the eye donation, and there is a drop of 52% of eye surgeries. So almost it's like a halt. So post-COVID, the hospitals don't advise for corneal transplants as there are various myths about the transplant. And even surgery doctors, like they now hesitate to go to, before we were like having house to house, I mean, going to the house, retrieving the cornea, retrieving the eye. But now all this has reduced drastically. And I think it's now time to retrieve all this. So as we know, cornea is a clear transparent tissue which is in front of the eye and serves as a window. And damage could be because of injury, infection, and diseases of the cornea. So eyes are really precious. And a recent government order now says that any dead, I mean, any patient who fails breathing can be taken as a donor. Means we need not get consent from other person of the family. So when the patient is dead, it is like they are legal for eye transplant, but we don't know like how far this law will be executed. So this is the recent thing that we have received from the government regarding the eye transplant. But whatever may be the infrastructures, the surgical procedures, they remain the same. Indian Journal of Ophthalmology conducted a study regarding the eye donation, and what they conclude is it highlights that barrier to eye donation in India is not cultural, religious, but more because of the misinformation and improper utilization of the donated tissue. So this study says that though we have a lot of infrastructures, lot of personnel, there is still a barrier of communication. So there are 1.8 corneal blind in India, out of which 1 million are children. And of course, as we know, the common causes are injury, malnutrition, infection, chemical burns, congenital disorders, and post-operative complications. So we need to get clarified ourselves regarding the primitive meaning of what is eye donation. Like even the doctors we see, the kith and kin we talk with them, like even they don't understand really what eye donation means. So for us to refresh these, so we'll really have to understand what is to be done by a doctor and what is expected from a person who goes for eye donation. So as we know, eye should be donated within 6 to 8 hours of death. And only cornea is used for transplant. Of course, now we do scleral patches also. So we can take a bit of sclera also for transplant. And there is a total removal of the tissue time is just 15 to 20 minutes. What we see here in the hospital or we see when we go for eye transplant is whenever there is a death, the family feels that if we give a consent for eye donation, there will be a prolongation of the cremation works. So they think the process will be postponed and all the relatives would have assembled. So they feel that it is a time consuming process. But eye transplant, I mean for eye donation, for us to retrieve the eyes, it will just take 15 to 20 minutes. And another myth is spectacle wearers, hypertensives, operated for eye, diabetic, everyone can donate. And eyes cannot be bought or sold. and all religions are endorsed for eye donation. And of course, the 10 cc sample of blood will be taken for screening the viral markers. And a call can be made for eye donation with the nearest eye bank. So IMA's Rajesh sir's effort we would appreciate, because there is a lot of confusion regarding whom to call. So the patient would have donated the eye to Aravind, but if like Coimbatore Medical College is close to it, they can always call us. So it is going to be used for someone who is in need. So call the nearest eye bank so that there will be no delay in time. And one more thing is, all the fans should be switched off and AC should be kept on. And if possible, we'll have to keep a wet cotton on the closed eye of the donor, and the head end should be raised. So only these are things which we expect the deceased relatives to do. So make a call and just elevate the head and then put a wet cotton on the closed eye. So what are the myths? There will be a disfigurement of the face, will be born blind in the next birth, will not be able to see God. So these are myths even we have in educated people. So there is no bar for age and there is no gender bar. So, and one more thing which we see is the deceased person may be interested in donor, but the relatives, the kith and kin, the family members, they little hesitate to do things. So the main thing that we would expect a donor to do is he has to educate whoever is close with him that after his death, his eye should be donated. So families can donate eye of the departed even if it is not pledged before. And one more thing, what people think is only if we have pledged, only if we have registered, the eye can be retrieved. It is not so. Even those who have not registered, those who are willing at the time of, if like a father dies, the child wants to donate the eye, then he can always call the site for the retrieval of the eye. So the person himself can make a voluntary will, or it is usually the relatives of the deceased who will let us know. And all these donations will be done only when there is a consent from the kith and kin. So generally these are the questions we'll have in our mind. Is it taken from the eye who are living? No, only after the death of the person it is removed. And is it the whole eye that is transplanted? No, the whole eye is not transplanted and it is only the cornea that is taken for a transplant. So how long can we preserve these eyes? So if there is only medium for preservation, we can preserve it for 96 hours for excellent results. So the term is known as corneal grafting or keratoplasty. And within 4 to 6 hours of death, we'll have to remove the eyes, and it is usually removed as a whole eye. And at times we even take buttons of the eye if the whole eye removal is not possible. And when it is in mortuary, sorry, this is an error, and it is 6 hours. So even when it is kept in mortuary, and now like we don't limit ourselves for 6 hours. We grade the eye based on the observation seen. And then if there is a gradable eye, we like take the eye. So who cannot donate? People suffering from hepatitis, AIDS, encephalitis, rabies, septicemia, leukemia, lymphoma, end-stage cancer disease. So what happens here is the death certificate becomes important. Even if the relatives are willing, like we will not do any procedure until we get a death certificate. Like we'll have to confirm the cause of death before taking the eye. So after donation, the family will receive an appreciation certificate from the eye bank, and the eye is evaluated at the eye bank. So previously, like before evaluation, we would like see the appearance of the eye by torch, and then we will do a slit lamp examination. Then we will put it in a specular microscopy. So there is a donor list and there is a recipient list. So we will match with the recipient and call these recipients. Like if it is a 20-year-old who is on the death, we will call a 20-year-old so that the eye will match with age and the count of the cells will be good. So recipients are notified first. Like the call will go to the recipient once we receive the eye donation and the procedure will be made ready. So the main thing that we have to educate now to the population is, like, we should not destroy the eye and we should be willing for donation just to see light on someone else's eyes. There is always, like every year we have a eye donation fortnight, which is from 25th of August to 8th September. So the awareness is only made in these days and there is no general awareness that is going throughout the year. So I think IMA Coimbatore has taken a right decision in a proper time. If it is done, it will be more beneficial to the needed patients. And all these actors, actress, they are like doing a lot of work, but then it should reach people in a proper way. So thank you, sir. Thank you for the opportunity.
Thank you, madam. We will have the discussion at the end now. About the questions also we will discuss at the end of all the 6 speakers. Now I invite Dr. Raja Sanmuga Krishnan from Ganga Hospital to give his talk about the recent trends in the skin donation. Welcome you, Dr. Raja Sanmuga Krishnan, sir.
Good afternoon, sir. At the outset, I would like to thank Rajesh Babu, sir, and the entire IMA team for giving me this great opportunity to speak about skin donation, which is a thing which not many people are aware of. Good afternoon, everyone. So today I'm going to speak about skin donation. So a lot of us would be thinking, would have heard about blood bank, eye bank, and we have also heard about the lung transplantation, kidney transplantation, liver transplantation, but very few people have heard about skin donation and skin transplants. Now, skin donation is common all over the world. It is picking up in India. The need is huge, but the availability is very, very little, sir. Now, skin bank is mainly used for burns. So, to know that, we need to know why are we using the skin. So I need to know the function of skin. Skin is basically like a fence. Things which are inside, it prevents it from going outside, and bad things from outside are prevented from coming inside. Like bad things like bacteria, heat, radiation are prevented from coming inside, and good things like nutrients, body heat, fluid, protein, electrolyte from inside, they're prevented from going outside. So it's actually like a good barrier actually. In major burn patients, the patient does not have enough amount of skin to cover the burnt areas, and hence what happens is the wound gets infected and the patients die. In such cases, the skin bank is of great use. So what do? Suppose if there is a deep burn means it attracts bacteria, it gets infected, and hence what we need to do is that we need to excise the deep burn and need to be covered with some skin. If we do not cover it with skin, the chances of infection are higher and the patient goes for malnutrition much faster. Now, just to give you an example, this is a small child who has come. You can see that they have already taken some grafts from outside and they try to put it onto this girl. This girl, you can see, is so malnourished. If you put any type of graft, they're not going to do well. Now, for these type of people, we have put the skin from the skin bank. And once we put the skin from the skin bank, we are able to build the nutrition, and then later on, the patient is able to do well, and this is how she has done well. And this is the same girl just after a few months. So basically, if you can see, if this girl has to become like this, it is because of this skin donation that we have done. How soon to call? We have to call within 6 hours after death. It is just like eye donation. Just like eye donation and skin donation have to be called within 6 hours after death. And who can donate? Who can donate? Who should not donate? It is very similar to that of eye donation. Anyone who can donate eyes can donate skin. So basically, they should not suffer from bloodborne diseases like HIV, hepatitis B, C, or from septic disorders. And that is why, just like the eye team, we also take the blood samples and to see that these people don't have these problems. Who can receive? Anyone can receive. Blood group, tissue bar, typing are of no bar. So because the reason is that we are only keeping it outside, and hence he can easily be taken off. Where can they donate? It can be donated in the hospitals. We can come to the hospitals. We can come to the house. We can go to the mortuary. Wherever you call us, we can come and then we can take it. It takes approximately half an hour to 40 minutes to take the skin. So where do we take the skin from? We take it from the lower limbs and from the back. Why we don't take it from the rest of the areas? Because for some traditional purposes, they apply a lot of kungumam. They put all kinds of things, sandanam over the face, over the foot, over the hands, upper limb, and that is the reason why we tend not to take skin from those areas. So a lot of people think if you're going to take a skin donation, all the internal organs will come out. No, it is basically just like a split thickness skin graft. Only a small part of the skin is harvested and most of it is retained. So if you look and see, means before harvest, it's like this. After skin harvest, you can see just whitish tissue. It does not bleed much because the patient is dead. And then after that, we also put a good dressing. And beyond this dressing, they can put their dhoti, pant, or whatever. And then we cut it in small bags like this, and then we take in glycerol, and then we go to the skin bank where we have to store it. We have to remove the antigenicity. It takes approximately 8 weeks for us to get it right and can be used for the patient. Now, a lot of people ask, does the skin last forever? The cadaver skin lasts for a few weeks, 1 to 2 weeks. But during that period, what we do is that we are able to build up the nutrition of the patient, the immunity of the patient, and the patient does much better. Skin from the patient is taken in stages to cover the burn. So this is how we do it. How long can we store the skin? We can store the skin for up to 5 years. So definitely in these 5 years, we'll definitely use the skin because the need is huge, the availability is less. So we're definitely not going to waste the skin that we take. And not only us, we take it, we send it to so many hospitals throughout the country. Just to give you an example, this is a case of a 40% deep burn. This is the upper limbs, you can see everything is very deep. And this is the same lady, you can see that she is walking in just 20 days. You can see how well she has done. So all this is because of the skin vaccine. We have taken everything and then taken the entire excised the entire tissue and replaced it with skin from the skin bank and also from the patient's own tissues. And this is another patient who came to us much later. You will see everything is deep and infected, and this is the final result. Immediately we can't take the skin because this will actually give rise to infection, and we will lose the skin. So first we put tissue from skin bank, and then later on we put autographs. So you can see that if you look at the number of skin donations that we have done is around 351, of which we have used skin for 244 patients. A lot of them are actually cadaver donors. That is, we go and harvest from the house or the mortuary. But the 120 were brain dead donors because we have taken it along with kidney donation or liver transplants. And it's not that we are only using it. When we have some extra skin, we also send it to various hospitals throughout the country, as far as even AIIMS Delhi, St. John's Bangalore, Manipal. We are given give it to 24 hospitals throughout the country. And this is all possible because of great NGOs like for example the SPIDA group who have by themselves have given rise to 150 skin donations. I think the thought for the day is that anyone who can donate eyes can donate skin. So immediately after death, within 6 hours after death, please donate eyes to give vision. Please donate skin to give life to burned patients. So both the things can be done within 6 hours. Who could donate, who cannot donate is very similar to eye donation. And so please do inform us whenever this happens. Thank you very much, sir.
Thank you, Dr. Sanmugh sir.
Thank you, sir.
Thank you for your nice lecture, and we will have the questions at the end of the session, sir. Now I invite Dr. Saravanan sir from Erode to give a talk about what are the recent trends in the kidney donation.
The EMA Organ Donation Committee President, Mr. Dr. Rajesh sir, and I thank for the opportunity that was given to me. So today we are going to see about the recent trends that has happened in the field of kidney donation. And as we all know, there are a lot of, as a nephrologist per se, I will tell even now, a lot of patients are losing their lives on dialysis, even though a treatment like kidney transplantation with more than 95% success rate is available for treatment. But many of the donations is not happening, and there are various obstacles and hurdles in the society to prevent organ donation from happening. So over the past around 1 year, Dr. Rajesh sir has taken various steps like conducting these meetings to overcome these steps. So as we all know, the kidney donation can be done in both living or deceased donors. And the demand of the kidney transplant is continuously increasing because of the increased burden of the ESRD, end-stage renal disease. So of the deceased donor, of the brain dead donors, we categorize into standard criteria donor, extended criteria donor, and donation after cardiac death. Standard criteria donor is if the donor age is less than 50 years and suffered brain death with ideally a traumatic case, because as a nephrologist perspective, we will usually have a high threshold to accept a kidney from a organ donor whose reason for brain death is a hypertensive bleed. We will also expect there can be some microvascular changes in the kidneys that may lead on to a delay in the organ recovery after transplant. So ideally, we go for a traumatic, that is road traffic accident case is ideal case for donation, and there should be no hypertension. See, this is standard, but we also accept other donors like with hypertension, etc. That depends on the recipient status. If the recipient is very high risk, if the patient is losing their vascular access, we will usually go for vascular access criteria. If the patient is losing all the vascular access, if the patient is on perm cath and all, we may accept a higher age donor with proteinuria and hypertension, etc. So from donor identification to transplantation, all these steps has to be followed. And first, the donor identification should be very widely performed in all the ICUs, and there should not be any hesitancy for the treating consultant to identify the donors. Only if they identify the donors, that is in a comatose stage in any ICU, they have to perform this apnea test first to identify. If they identify only, they can give a proper counseling to the family about the prognosis. And then the next step is imminent death, and then referral to an organ procurement organization. Or not all hospitals can do the procurement surgery. So then before that referral, the assessment of donor suitability, whether the patient is on inotropes, etc., and to get a clear consent before shifting for donation is a very important step. We usually advise the grief counselor of the hospital to go through this step to identify the donor and getting a consent after the counseling from the parent unit. And then organ allocation will be done by the transplant. And then even after shifting the patient to a organ procurement center, there should be an intensive management of the organ donor so that the mean arterial pressure is managed, and then other useful, that is the liver donation and kidney donation is solely dependent on the mean arterial pressure management of the donor, and organ recovery surgery and organ preservation and transportation and transplantation. So these are the steps And traditionally, in the lay legal and medical communities, death has been determined by an irreversible cessation of cardiac and respiratory function. And kidney can be harvested from patients who are suffering from brain death and cardiac death. So that of brain death, the most of us knows about the we confirm the brain death with an apnea test, and it should be irreversible. The brain injury should be irreversible. We also usually wait for at least 48 hours after the patient is getting transferred inside the unit, and to look for any reversibility of the brainstem function and cerebral function. And it should be made by the physician who is independent of the transplantation team, so without any conflict of interest. So the reversibility, that should be irreversible. The comatose stage and the brainstem dysfunction should be irreversible. There should not be any sedation. No paralyzing drugs should be there. And gross electrolyte imbalances like very high gross hypernatremia or hypothermia should not be there. And no profound hypothermia. And all these, no seizures, no response to any pain, absence of brainstem function, and no pupillary or corneal reflexes should be there. So this is the apnea test. Before you doing the apnea test, we have to pre-oxygenate with 100% oxygen, baseline ABG, and then administer a disconnect ventilator or administer oxygen and observe for respirations. And you have to draw the ABG in 8 to 10 minutes, and the CO2 increase should be documented. And if even with an increase in CO2 of more than 60 millimeter of mercury in ABG, if there is no respiratory effort, then that comes an apnea test. So donation after cardiac death, and also called as non-heart beating donor, before the acceptance of this criteria for the declaration of brain death, deceased organs were recovered from the patients with cardiac arrest. So at present, as a nephrology point of view, the problem with this cardiac death donation, yes, the warm ischemia time of the kidneys will be very high. So the reversibility of the kidneys function after transplantation will be very minimal. So we, at present in our state, we are not following this donation after cardiac death. And this is the mass fit criteria categories, and dead on arrival, category 1, unsuccessful resuscitation, awaiting cardiac death, and cardiac death in a brain dead donor. In all these 4 categories, donation is happening in Western countries, but when we consider the outcome of the transplantation after the transplant, then these categories, this will be very much difficult to do in our setup, and then we are not doing all these things. So this category 1 and 2, pulseless and asystolic after adequate but failed attempts, are not actually performed. So all these categories donors we need not see. So the role of the organ recovery team. See, the organ recovery team plays no part in the diagnosis of death. Only after a brain death, the patient is usually counseled by the parent consultant or the treating consultant, and a preliminary consent will be procured in a center wherein the patient was initially admitted, and then only the patient will be transferred to our center for further proceedings. This category 4 donation after cardiac death or crashing donors, this usually happens in any ICU who is taking care of a brain dead donor, because these patients' mean arterial pressure should be very much managed with inotropic supports. And if the patient donor is on high inotropes, then immediately we have to take steps to proceed for organ recovery procedure, because patient can go into cardiac death at this time, at any time. So patients who have often become hemodynamically unstable to recovery after a brain diagnosis of brain death, this is called crashing donors. So once a potential organ donor is identified in an ICU or in an emergency department of any hospital, the term imminent death has to be used, because until we confirm apnea test with a brainstem death, we cannot call these individuals as brainstem death patients. So imminent death, a patient with severe acute brain injury who requires mechanical ventilation is initially admitted in ICU or emergency department and has clinical findings consistent with Glasgow Coma Scale. So this scale, it should be 4 or less should be the criteria. So Spanish model, the presumed consent legal framework that assumes all suitable patients upon death will donate their organs. In many of the Western countries, a lot of this licenses that they have already have printed like as if they are willing to donate for the organs once they are found brain dead. So families retain the right to refuse permission, even if that is there. And if we have this model to be strictly followed in our Indian law, it can produce high organ procurement rate. Usually, the donor evaluation will be tested for hepatitis C, HIV, or HTLV virus, hepatitis B virus, and cytomegalovirus, and Epstein-Barr virus, and syphilis. And HIV seropositivity is an absolute exclusion criteria. And the expanded criteria donor, many centers have started using this expanded criteria to be used for transplantation. It defines as any age more than 50 years and with a history of hypertension, death as a result of cerebrovascular accident, or even with a creatinine of 3 to 4 milligram per deciliter creatinine are nowadays being used for transplantation because of the uh, very a small number of donors with standard criteria donors are available. And even with those transplants, we expect a good um, success rate up to 85%. So ECD donors accounts for around 15% of the deceased donor kidneys, and at least 70% increased risk for failing within 2 years compared with the standard criteria donors. These sectional criteria donors or kidneys are usually given to persons with high risk rate on dialysis. If their imminent life-threatening situation is there on dialysis for any ASRD patient, these patients will be considered for this external criteria donor. So in living donors, we usually do not, any center is not accepting any unrelated donation that is for any financial benefits, and informed consent is at the core. So a living donor is a competent adult who has a, very 18 to 70 years, body mass index is less than 35, and there should not be any active infection or adequate renal function that is demonstrated with the 24 hours urine create clearance and also the DTP urinogram with split renal function. These are the usual donation evaluation that we give. Socioeconomic evaluation is the present criteria that we usually start following. We usually get the donors 1 year of bank statement. So to verify whether any financial benefit has happened before the time of evaluation. And then is the psychiatric evaluation, whether the donor is truly willing to donate or they are donating under any forcing such circumstances. The medical evaluation like renal function, as I already told, 24 hours proteinuria, and to look for hematuria, GFR estimation, and to rule out hereditary renal diseases has to be done. And ultrasound should be done with structural to rule out structural abnormalities. Cardiovascular disease, if the patient is a high-risk donor, if the age is more than 60, we usually advise them to also undergo coronary angiogram. If the patient is age less than 60 years, an echo and a terminal evaluation to rule out any reversible ischemia is sufficient. And the donor should be not be having any infectious diseases like hepatitis B, C, or any of the cytomegaloviruses. And the malignancies should be ruled out. And only after these evaluation, patient can be considered a probable donor. And psychosocial evaluation, like exploring the donor motivation and excluding the coercion, should be done on the consultant's perspective, because for human organ transplant clearance is giving the importance only to the nephrologist and the urologist who was performing the transplant. We cannot, if there is any coercion that is involved in this donation, then Human Organ Transplant Act is not accepting any of these problems, because the Human Organ Transplant Act has clearly told that the nephrologist and the urologist who is signing the affidavits and all these consents are the primary responsible persons for this donation and transplantation. So it is the nephrologist and the urologist role who is signing the document that is going to be sent for the HOTA committee should be excluding all these coercions, and they should be very much responsible enough to take up that responsibility. So this ruling out of significant psychiatric problems should would impair the person's ability to give informed consent. So psychiatric problems, if it is there, we have to get a psychiatrist opinion to rule out that. So medical evaluation, and nowadays we have started performing ABO incompatible transplantation and cross-matching against the potential recipient and HLA tissue tapping, and everything is there. And choosing the donor, if the patient is having more than one donor, suppose if the patient has mother as a donor and father as a donor, then we usually give the HLA cross-matching and the donor age. And the biologically related donors are generally preferred because we can reduce the immunosuppression to a very minimal level. So if the donors have a similar match grade, then we can go for the older, younger donors will still be available for donation if for future donation. The present donation can be performed with the older donor. So if the usual time period of around 5 to 10 years for the kidneys to work, if it is over, then for the second transplant, we can consider the younger donor age. So the even advanced age, we recently performed a transplant with a donation of more than 72, that is 72 years, recently in before 2 months. And once we are able to rule out all the end organ damages in a very profound way, then we can accept a donation even after 70 years. And 18 years is the lower limit for donation for living related donor. So these are general assessment, and if the patient is sufficiently healthy to undergo the procedure, usually many centers have started using this laparoscopic kidney donation. With the laparoscopic kidney donation, the patient can walk within 24 hours, and patient can be safely discharged within 4 to 5 days. And because of the post-operative morbidity is very, very less with laparoscopic kidney donation. So has normal kidney function with minimal future risk for kidney disease is there. And patient donor is not at increased risk for medical conditions that might require treatment that could endanger his or residual kidney function. So these are the usual lab tests that we perform. And prostate-specific antigen in men more than 50 years and older individuals has to be done, and human coronary HCG test in all women younger than 55 years is a must, and serum protein electrophoresis in donors more than 60 years also should be done to rule out any light chain deposition disease or occult multiple myeloma that can be a reason for future problems for the patient. So the other tests like ECG, X-ray, and everything is done, and these are the usual absolute contraindications. If there is any evidence of renal disease, like GFR is only less than 80 ml, then these patients cannot donate. Active malignancy, chronic illnesses, and poorly controlled psychiatric illness, cognitive deficit, current pregnancy, hypertension, uncontrolled with multiple medicines. Diabetes mellitus is not yet considered to be an absolute contraindication. If the present criteria with diabetes mellitus with a very good sugar control in HbA1c less than 7, without any end organ damages obviously visible, that these patients can be considered for kidney donation if there are no other donors possible for the recipient. If the donor is accepting the risk out of this donation, then we can proceed. And if there should not be any history of recurrent nephrolithiasis, and there should not be any history of thrombotic disorders. So the relative contraindications is this, and patient, if it is their obesity, BMI is more than 35, then we have to ask the patient to lose weight and then come back. And then proteinuria, any proteinuria greater than 250 milligram per day, we cannot accept as a donation organ donor because of their high risk for developing renal disease in the future. The transient cause of proteinuria like fever and UTI should be excluded before we decide the patient cannot donate. And hematuria, donor candidates with persistent isolated microscopic hematuria may require complete urological evaluation. Cystoscopy should be done to rule out bladder pathology. In the absence of any specific abnormalities, even a kidney biopsy may be necessary to rule out IgA nephropathy. If the patient is having thin basement membrane disease, these patients can donate. But if the patient is having IgA deposition, those patients cannot donate. And chronic pyuria, UTI, and prostatitis should be ruled out. If there is no obvious infections, Then a renal biopsy to rule out interstitial nephritis or chronic pyelonephritis may be necessary to rule out pyelonephritis, and the renal tuberculosis should be done. So inherited diseases should be ruled out before considered for donation. ADPKD, Alport syndrome, thin basement membrane disease, familial primary glomerulonephritis, sickle cell disease, and SLE. So nephrolithiasis, prospective donors with distant history of stones, that is more than 10 years, but without any obvious metabolic abnormalities can be considered. But cystinuria is a contraindication, and primary or entering hyperoxaluria is a contraindication for only kidney donation. Now we have a patient like hyperoxaluria who is going to get a liver transplant first done to reduce the oxalate load of the patient, and then only the kidney transplant can be done after getting the oxalate load normal. History of screw-weight stones contraindicate trust donation. So cardiovascular risk assessment, as I already told, ECG is sufficient, but if the patient is diabetes, if the patient has high risk, then even we have to go for coronary angiogram to rule out significant disease, coronary artery disease. Communicable disease transmission should be ruled out. As I already told, we have gone through these slides before. So these are the increased risk of CDC donor, and men who have multiple sexual partners, and women who have had sex with men more than MSM behavior in the preceding 12 months, people who have had multiple injections, IV drug abuse, they have increased risk CDC donors. So the malignancy transmission, age appropriate screening tests should be done. Certain cancers in history or contraindications for kidney donation. Usually, if the patient donor have any history of malignancy over the past, they should be absolutely disease-free for the past 5 years at least to be eligible for kidney donation. So the contraindicated malignant history, melanoma, renal cell carcinoma, choriocarcinoma, and hematological malignancies with gastric carcinoma and Kaposi sarcoma, they cannot donate. So women of childbearing age group cannot donate. And these incidentallomas are detected like adrenal nodules in small portion of patients when they undergo the CT angiogram. And if the adrenal lesions meets the CT criteria for benign adenoma and a functional metabolic workup is negative, proceeding with donation is reasonable. Calcium calcification, we have to do metabolic evaluation. If it's found to be normal, they can donate. Renal lesions, about 30% of the kidneys evaluated with CT have incidental renal pathologies such as low density lesions and renal cysts and calcium calcifications. This information does not necessarily preclude donation. We have to evaluate and take a decision. So biologically unrelated donors, at present, we are not getting a clearance from the HOTA committee. And if they, and it constitutes around 40% of the living donors in the Western countries. And this is non-directed donors, which I'm going to show in the subsequent slides. And this is that living donor paired exchange. To overcome this waiting list in this cadaveric transplant program, we can plan for the swap exchange, that is two pair exchange. Suppose if there is any ABO incompatibility or HLA incompatibility between the donor and the recipient, suppose if this donor and the recipient is the pair number 1, if there is any ABO incompatibility, suppose if the recipient is O group and the recipient is B group and the donor is A group, suppose if they have this ABO incompatibility, then we have to find an adequate second pair wherein this donor of A group can directly donate to the A group of the recipient in another pair, and this is exchange of the donation can happen. This is called 2-pair exchange, and this is called 3-pair exchange. All these things is very much necessary about the donation of the blood group of the recipient and donor. And nowadays we are forming a registry across all the dialysis centers, and that software is under process now, wherein all the possible donors and recipients, they will enter the blood groups, and then only because we cannot search for an identical like this pair in one dialysis unit, we may need to search for in other units also. So this is called the donor chain. Suppose if there is one non-directed altruistic donor gives the donation, then that can start this chain of donations, and these things have not been done in our Tamil Nadu setup, but it is possible in other countries. So we are coming to the end of this slide. This is how we usually give the body of the donors, and it is a good habit that all organ harvesting hospital make all the staffs to assemble at the time of we handing over the body to the family after we conduct 1 minute of silence, and then we can just put in a small garland to the donated persons in front of their family and give their uh, um, honor. And this is how this is when we conducted a recent event wherein Dr. Abulasan sir was there as state IMA president, has distributed an organ donor um, small honor to the patient family after the donation, because these people has to be given a due credit even after the donation is done. So thank you, Dr. Rajesh sir and other speakers for giving me this opportunity. Thank you.
Thank you, Saravanan sir. We will have the questions at the end of the other three talks. Now I invite Dr. Vijayanand sir to give his lecture on the recent trends in the liver transplant. எங்க பேசுங்க சார் அவர் சப்சிடி Good afternoon, all. Sir, you are audible. Audible, sir. Okay. Okay. Good afternoon, all. I'll talk about recent update in liver transplant. I thank IMA team for giving me this opportunity. So, how does the liver look? This is what you can see in the laparoscopic view of the liver, normal liver. So, liver is divided into multiple segments. So, any damage in the liver can change the texture of the liver. So, these are all the segments in the liver, what you see. So, next, what you see on the left side is a normal liver. What you see on the right side is a damaged cirrhotic liver. So, what are the things which damages the liver is viruses, hepatitis B, hepatitis C viruses, and hepatitis A, hepatitis C sometimes advanced along with the B and C can cause the damage in the liver and cause the liver cirrhosis. Too many fatty foods is the one which recently has come, called as non-alcoholic fatty liver diseases, and too much intakes of drugs and medications like paracetamol, other medications can damage the liver. Alcohol is the one which is the most common etiology for all the damage of the livers. And recently, this rat killer poisoning, which has been banned in Tamil Nadu, which has been taken in some places in an area of around Attur. So we get a lot of rat killer poisoning, so those who require liver transplantations. So what does this causes? See, any continuous insult to the liver damages the liver and causes a chronic liver disease, which is called as a cirrhosis. Next is called as an acute liver failure. Acute liver failure, the liver is normal. Sudden insult like hepatitis A, hepatitis C, E viruses, any unknown causes, ATT drugs, all these things can cause an acute liver failure. Acute or chronic liver failure, the liver which has been already damaged will be affected with insult by some other infection or sometimes with hepatitis A, hepatitis E viruses. Sometimes the liver malignancies, the cirrhotic liver which can turn into a malignancy can also be one of the cause for a transplant. Other rare diseases can be causes like autoimmune diseases can be one of the etiology for the liver diseases. What will be the symptoms? The patient usually manifests with the compensated cirrhosis, decompensated cirrhosis. Compensated means they won't be having any symptoms. Only the symptom will be just an ultrasound finding of a cirrhotic liver, which will be done usually at the time of a master health checkup. Next is usually the manifest of the decompensated cirrhosis. The patient might initially present with a pedal edema, or sometimes with mild ascites,
jaundice, all these things are all the symptoms. Advanced disease, patient will present with hepatic encephalopathy, high jaundice levels, recurrent upper GI bleed, melena, chest in the fluid, hydrothorax, ascites, pedal edema, acute kidney injury. These are all the advanced cirrhotic symptoms. Is there a medical treatment? Yes, all the diseases has got a medical treatment before a transplant. So liver is the one which is a unique organ from others, because if you stop the insult, say suppose if the patient is alcoholic, you stop the alcohol, liver can regenerate. Who will require a liver transplant is there is a scoring system for a liver disease. As for all the other diseases, like liver has also got a scoring system called as a MEL scoring system. Any patient is the computer generated scoring system. So you enter your creatinine, bilirubin, INR, all these things into the MEL, computer generated scoring system. It will give you a value. Any score above 14, the patient will require a transplant. As the score increases, the results will be not so very great. So when you do a transplant between 14 to 20 of MEL, the results will be very good. When you cross above 20, 25, 30, all these things, the results won't be very satisfactory. But there is no other options. You have to do only transplant for these patients. So what are types of liver transplants available? Deceased donor liver transplant. Next is a living donor transplant. What you see on the left side is a deceased donor liver transplant. In this, the entire damaged cirrhotic liver is removed and is replaced with a new liver, which is got from the organ donation. And next is the living donor transplant. In this, part of the liver, right lobe or left lobe, can be donated depending on the patient's weight. So we inaugurated our transplant department in 2015. We initially started with all the cadaveric transplant. Then we progressed to the living donor transplant. Now we have started doing all the pediatric liver transplants also in our center. So this is the youngest child in Coimbatore for whom we did a transplant, 6-month child, for whom we did a CRRT. The child came with an acute liver failure of unknown cause. So we prepared the child and we get transplant, and the child is doing well. So what disease donor transplant? So disease donor transplant, there is a criteria. As Dr. Saravanan was mentioning, all the policies when to do a disease donor transplant. So the government allots the liver. So as like a kidney, liver will be allotted to different hospitals depending on the rota system. So whenever we get the liver alert, the patient who has been already prepared and listed in the list will be informed. So a patient comes to the hospital, we check all their vitals, everything, and found there is no infection. Then we plan for a disease donor transplant. One of the team goes for the liver retrieval. So to retrieve the liver from the brain dead patient. Other team prepares try to remove the cirrhotic liver from the in-house hospital. This is how the liver which has been explanted from the deceased donor liver is being flushed with the UW solution, which is a preservative solution which is used to flush the liver and remove all the blood inside the liver to store the liver. So you can see the color change. The liver which was red, which is being flushed with the solution, it turns into almost white and is being plaqued with the ice. And the liver which is harvested from this hospital will be transported to our center for the implantation. There will be other team who will be preparing the liver, try to remove the liver. See, problem in a kidney transplant is there is no need to remove the kidney. You can place the kidney in another in the right iliac fossa or left iliac fossa. In case of liver transplant, you should have a good 2 teams to do a transplant, because one team can't do everything. So one team prepares the liver, harvests the liver from the donor. Another team prepares the bed so that the entire liver is removed. And because you have to be very careful, because cirrhotic liver is very dangerous to operate, there will be a lot of blood transfusion required. So you have to be very meticulous. So you should have an adequate, good trained team in case of a liver transplant. So the liver is being brought to our hospital now. There is another team who is operating on the cirrhotic liver. We'll be showing that video now. This is how the liver is brought. The liver is allotted by the government. See, this has another team who is retrieving the damaged liver now. So after removing this damaged liver, the liver which has been brought, so this is the cirrhotic liver which is removed now. So the liver which has been brought is being prepared for implantation now. So you can see a nice good liver which has been donated from the donor family. So the liver, there is no liver in the abdomen now. The entire damaged cirrhotic liver is removed. So new liver will be placed inside the abdomen. So you can see the new liver which has been brought is being placed now. This is the deceased donor transplant. What is the advantage in case of deceased donor transplant is you get a full liver. In case of a living donor liver, there will be you get a part of a liver. So coming to a living donor transplant, who is the ideal donor? Ideal donors should be a family member, ideally between 18 to 55 years, with a normal and good liver function test without any viral positivity and less fatty liver. So we are the center, we do almost all the donor by laparoscopically. So you can see what you're seeing is a laparoscopic view of the normal liver, donor liver. So the liver is mobilized now into right and right. This is the right vein and middle vein. The special instrument called as Goldfing, which passed under the IVC and brought out. So all the right hepatic artery, right portal vein, all are delineated now. So now we give a special dye called as an indigo cyanin green after clamping the things. So it will exactly delineate the river into right and left. So now you can see the liver right and left. So we mark the liver into right and left. Now we divide the liver with a special instrument called as a CUSA. So this is a harmonic scalpel. So without blood loss, we are dividing the liver now. So what you see is a CUSA. CUSA is a special instrument which is used specifically for a liver surgery and brain surgery. It identifies and delineates the veins. So you can identify the veins and clip it properly. So difference between the normal cancer surgery and the donor surgery is you have to preserve all the vital structures so that you have to reuse these structures for the implantation in the recipient. So liver is divided with the staplers now. So right artery is clipped and divided. Portal vein is stapled. So now you can see the right and the left lower liver. So the liver is removed through a small phalangeal incision like a cesarean scar. So after taking that liver, what we do is, see, this is how we delineate the liver into right and left system, the special instrument. This is a damaged liver which is being removed now. So the living donor graft which has been removed is being prepared for implantation. So you can see a right vein is being, plasty is being done around the right lobe. So the liver, damaged cirrhotic liver is being prepared now for a explant. So now the entire liver, cirrhotic liver is removed now. So the right hepatic vein is open. The new liver is the living donor liver, which has been brought out. It's anastomosed now. Right hepatic vein, portal vein, right artery, and biliary system will be anastomosed. So the portal vein is being anastomosed now. You can see the new entire liver now. So we are the first center in India to do a laparoscopic surgery by the donor surgery. And nowadays we have started doing the recipient surgery also by laparoscopically. So we remove the liver by robotically. So this is a robotic surgery. What you see here is a robotic surgery. So we remove the cirrhotic liver robotically and place the new liver. So we have got a dedicated transplant ICU for maintaining a post-operative management. And basically transplant is a teamwork. It's not an individual play. So it's like a cricket team. And everybody has to do their work. Then only you'll be able to give a victory for the team. So post-operatively, was the problem is like rejection, but rejection rate of liver is comparatively less compared to the kidney because it is not there is no any antibiotic-mediated rejections much in case of a liver transplant. Main problem in the liver is all these surgical related complications, bile duct strictures, all these things are all the major things which causes a problem for the surgeon. But everything can be handled. Rejection can be managed with adequate immunosuppression. And post-operatively, the patient do well with the without much infection, that the surgery is done at right time. This is the child for whom we have all transplanted. These are all small child, the youngest only 6 months in our zone. We have a special thanks to the entire team. For financial, major problem comes in case of a transplant is the finance. So we have got a CM scheme which gives around 16 lakhs from the government, another 6 lakhs for 2 years. The government gives the medicine, and we have got a foundation to give fund for us. And there is Praveen Agarwal Foundation who fund these pediatric cases. Now, online funding is also done by Keto and MyLab groups. So you can see the child for whom we have transplanted now is very active. Almost the child is 1 year now. This is a new life after a liver transplant. So this patient underwent a liver transplant. Now he is able to do all his day-to-day activities. The donor was his wife. She is able to do all her daily activities. So the liver transplant can be done with the good results. It's a special thank to the entire team for making this one. Thank you all. Sir Rajesh sir? Hello? Hello?
Yes, sir. Yes, sir.
Yeah, questions I'll take last, sir.
We will take a last, sir. Now I invite Dr. Kalai Anbusudar, Professor of Anatomy. Screen sharing stop on here.
Good evening, sir.
Yes, madam.
Sir, are you able to see the slide, sir?
Yes, madam.
Thank you. Good evening, everyone. I'm Dr. Kalai Anbusudar, Professor and HOD of Anatomy, Government Mohan Kumar Medical College, Salem. First of all, I thank our Dr. Rajesh sir for invited me here for the CME program. Thank you so much, sir, and thank you everyone in IME. And we had a very nice topics today. Thank you so much to all speakers. My topic is on body donation. Most of the time, people are aware about organ donation, but not much about the body donation. What actually body donation means, it is a whole body donation. As we all know, what we use in anatomy department for studying this anatomy. So many of the public, when they come to our department, they ask about organ donations. But they are not aware of body donation. But nowadays, some awareness is created in the society, and people are coming to donate their whole body after their death. We know that cadaver is the first teacher for all MBBS doctors. Previously, procuring cadaver was very difficult. In olden days, when we were MBBS students, they used to get only unclaimed bodies, unclaimed or unknown bodies. Still, we receive unclaimed or unknown bodies, which should be declared as unclaimed or unknown by the police people. But it will take time for us to get this unclaimed or unknown body to our department. But in nowadays, what happens? Most of the medical colleges, we receive donations, body donations from our public. It is made very easy nowadays. The procedure is also made easy by the government to donate their body after their death. We receive bodies after their death by their willingness, and we preserve it in our anatomy department. It could be preserved for years together, we know. And cadaver oath will be taken on the first day of starting the dissection for the first MBBS students, and we give due respect to the cadavers before starting dissection every day. This is what we do when we start dissection for the first day for the first MBBS students. This is the picture of cadaver oath, which we have taken last month in our anatomy department for the 2024 batch MBBS students. And daily we, as our previous respected speaker told, we give due respect to the cadavers every day. We keep 1 minute silence before starting dissection. Because it is very, very important to give respect to the cadavers. That is why then only the MBBS students will understand the importance of getting this cadaver and the difficulties in procuring the cadavers. Body donation, few guidelines are there in our government. This body donation is done in all anatomy departments of all government medical colleges. Application forms are also available in all government medical colleges and also in our college website. And they have to fill this form, and along with that, they have to give it in 100 rupees bond, stating that they are willing to donate their body, and all legal heirs should sign in this form, and the notary public should approve this with 2 witnesses. And we inform them that only natural death will bodies of natural death will only be accepted, not the MLC cases and all. After registration, we give them a registration number. They can have it in with them when they come for donation. They can refer this reference registration number, and even unregistered body will also be accepted in our government. In case of unregistered body donation, the legal heirs or the family members of the deceased, the legal heirs have to give no objections letter and willingness letter also to donate their body, their parent or somebody else in the family, with the 2 witnesses. And death declaration should be done by a registered medical practitioner. The cause of death, the time of death, everything should be in detail. In case of donation of bodies, what are the documents to be provided? There is if it is before death, the individual is donating, there is requisition from the individual person and their legal heirs. No objection from all legal heirs with 2 witnesses and death declaration, and only non-MLC cases are accepted. And the same time, we inform them that cadaver will not be returned at any cost for any reason. Sometimes what happens in our medical colleges, we come across so many cases. For example, person is willing to donate his body. He will give a consent letter to us, application, everything with the legal heirs sign, with witness sign, everything. But after his death, his wife or his legal heirs may object this. In this case, we will not take the body. And the same time, a few days later or few months later, one of the legal heirs might be in abroad, will come and ask, without my knowledge, they have given, so please return back. So we cannot return at any cost. And the same time, we will not allow them to see the body after donation. So all these things we will explain them. And anybody can donate body at any age. They can donate their body. Even minor below 18 years, if the parents are willing to donate the body, they can give a consent letter on behalf of their children. But after 18 years, that individual has to give a consent letter if that person is willing to do it. Otherwise, if the individual is not willing to donate, they can withdraw it also. They can tell that without my consent, my parents have given, but I am not interested. In case they can withdraw the donation also. And anybody can register for donation at any time, at any age. And if not registered, the family members can donate after their death. The persons who has HIV positive, hepatitis B positive, COVID positive cannot donate the bodies, and MLC cases also cannot donate the bodies. In case of when the person is coming to us to donate, sometimes in our anatomy department, we see people come to register their body for donation, but they are under below 30 years, between 20 and 30 years. they may be in any psychiatric disorders or in depression, something like that. They will think that there is no use in living in this world. We can before our death we can register here. It will be useful for somebody else in future, like that. They will donate here. And without the knowledge of their legal heirs or parents, they will come and ask us, but we'll counsel them. What they do after registering here, they will commit suicide also. We have come across cases like this in 10 years before. So we don't accept it. At the same time, we don't encourage them without their family members support, and we counsel them and we send them to psychiatry department to give counseling and explain them not to donate now. And body donation should be given within 8 hours of death. For that 8 hours, it should be kept in the freezer box. Decomposed signs, if the decomposed signs has started, it will not be accepted for donation. This is the form which is given by the government for body donation, registration for body donation. And these are all the documents they have to add with this, the Aadhaar card and ID marks, everything they have to give along with the 100 rupees bond. And this is the sample bond for body donation with the legal heirs sign and the witnesses sign. And this is the legal heirs sign, which is approved by the notary public, an advocate. This is the letter we give them after registration with their with the registration number, and then they can contact these phone numbers after their death. The family members can contact this phone number to donate the body. And this is the format we give them if the family has donated the body to us, to our department. This is a thanks letter we are giving to the concerned family to thank them, because from which our students, of course ourselves also, study our anatomy. That is what. Thank you so much for the opportunity you have given to me. Thank you, sir.
Thank you, Kalayan Sudar Madam. Now we invite Dr. Ramalingam sir, the Professor Dr. Ramalingam sir, to give his lecture about the role of urologist in the organ donation.
Hello.
Yes, sir.
Hello. Good evening, Dr. Rajesh and all the IMA office bearers for giving me the opportunity. Are you able to see my slides, Rajesh?
Yes, sir.
Okay. I think my previous speaker might have told you about the organ donation and the legal aspects, which probably I will share in my last slide. I thought I'm going to talk on that also. But anyway, I will talk about the urologist's role in kidney donation. Okay. So coming to the renal donor workup, all of you will be aware that baseline hemogram, renal function studies, liver function studies, thyroid function studies, cardiac workup, basic ultrasound of the kidneys and associated abnormalities of other organs, CT renal angio to plan which side to take, and viral marker, of course, and once we finish the cross match, then we do the isotope renal scan to find out which kidney to be donated, because we need to preserve the better kidney for the donor. So coming to the recipient's workup, we need
Sir,
to go.
Ramalini sir, full screen போடுங்க sir. Full screen போடுங்க.
Okay. Slide. See better?
Yeah.
Okay, okay. Coming to the recipient worker, we need to know about the bladder anatomy and the emptying. Whether there is any obstructive features or any refluxes. So that we need to do. And then when there is a lot of residual urine, then we need to do what is called a urodynamic study to know whether the patient will be able to empty the bladder post-transplant. So suppose you have a 70 years person needing a transplant and he has diabetes, he has got prostate, then sometimes we even do TURP before transplant, because post-transplant we don't want him to be going in for acute attention. Sometimes when you have a huge kidney occupying the space, then like APDKD, polycystic kidney disease, then we even do native kidney nephrectomy. Sometimes when the patient's BP is uncontrollable, we do native kidney nephrectomy to make the patient fitter. So these are the baseline workup. So conventionally, we don't take up patients with cyst or any other disease in the kidneys. But in the USA guidelines, I am one of the authors for the guidelines set up in the system of the Urology Society of India. So I was in charge. So we even extend the indications, like if the patient has a small stone or a simple cyst, we remove it either prior to the donation or at the time of lab donor, we tackle that one. We even extend the borders that even if the patient has got a small renal tumor also, then that also we accept. We do the ureteroscopy intraoperatively for the patient who has got stone. This is a case of renal cyst. So intraoperatively during the bench surgery, we remove the cyst and then go ahead with the transplant. This is a patient who has got small stones. We use a ureteroscopy and then remove the stones. And then that's how we do the laser or the flexi-URS and remove the stone and then do the recipient surgery. This is a case where the patient had a small renal tumor less than 4 centimeter nowadays are some of them may be even benign. So we remove the tumor in the bench and then go ahead with transplant. So the extension of, if that is the best match one can have, so we do the marginal donors also. Coming to the donor surgery, last 10 years or so, we have been doing only laparoscopic donor nephrectomy, contrary to the most of the centers which do open surgery, where you make a rib cutting and then about 25 centimeters of incision, and the patient will not be able to go home next day. But in a lab donor, the next day patient can go home. We make a small incision in the suprapubic area and then retrieve the kidney. Coming to the lab donor nephrectomy, I think most of you will be aware about the how we do it. This is a video. These are all the ports we make. And then we mobilize the kidney. Laparoscopically, all the pedicles will be mobilized. The ureter will be mobilized. This is a mobilization of the pedicle, renal artery and vein. And then we detach all the attachments and then cut the ureter first, then the artery second, and lastly the vein. And sometimes we do even risky cases, like this is a case of crossed fused ectopic kidney. So even this is generally very difficult to detach one kidney from the other one, but we do this also by laparoscopy. You can see the anatomy is totally changed. the artery goes in front of IVC. So technically it will be very challenging, but still it is doable. And you can see here the anatomy is totally different. So we detach the right kidney from the left one, and then control the vessels, and then retrieve the kidney, the phalangeal incision. So this is the perfusion, and this is the retrieval of cadaveric kidney. We make a long midline incision. Rajesh was there when we did the second cadaver transplant in whole India in KG hospital. I think it was in 1994, Rajesh, am I right?
Yes, sir.
94 we did, and then we subsequently did about 12 cases at a stretch in few months, and then we never had any exposure in India how to do it, but still we did it. Sometimes when we do a cadaver transplant from a child to a parent, then we do what is called a dual kidney. We take both the kidneys, perfuse along with the patch of aorta and IVC, and then do the transplant. That will be very challenging in the cadaver surgery. And this is the small video of the how you do the renal transplant. We make an incision in the right iliac fossa, prepare the bed. That's the first we do the vein anastomosis. So once that is over, then we go ahead with the artery anastomosis. That's the arterial anastomosis. Then we do the release the clamps to see whether there's any good perfusion, any hematoma, any bleeding. You can see the urine coming out immediately. If there's a good match, then there shouldn't be any problem. Then we do the reimplantation. So that's finishes the transplant. Technically, all the techniques have been mastered. It's time tested and nothing to. Only new thing is, I will cover up a little bit about the new thing. Conventionally, we make about 20 centimeter incision in the recipient surgery. But of late, in the last 2-3 years, Indians urologists have been the torchbearers in demonstrating robotic transplant. So all that you need is about a 5 centimeter incision in the subumbilical area. We have a port called Alexis port. Once perfusion is done on the bench, then we place the kidney through that port, and then doing robotic transplant. There are about 20 centers in India who are all doing the robotic transplant. So technically it will be challenging, but the plus point is the wound infection will be less because the incision is only 5 centimeter, which is very common with conventional transplant. Maybe about 5 to 7% of the patients develop wound infection. But here, when we do robotically, the wound infection is much less. So that's one recent advance. And once that is done, using the peritoneal cover, we make it extra peritoneal. So it will be exactly like what we do in the conventional way. We cover it up with the peritoneal fold. Now I want to share a few of my thoughts about the future of renal failure management. We have what's called pig kidney transplantation. It's genetically tested, and first we have witnessed it being done in the University of Alabama, and the patient lived for a week. And then subsequently it was done on a cadaver or a brain dead person, and that worked for about 2 months. So that's a good sign that in the future we can go ahead with the xenotransplants. So because we are so much short of matching donors, we can get the xenotransplant. We are evaluating in a big way, and you can have a look at this, what is called wearable artificial kidney. Lot of research has gone in, and then even clinical trials have gone successful that you can wear a very only 2-pound weighing wearable kidney. You can wear it in the waist, and then don't have to go to the dialysis unit, huge unit, connect all the monitors, and then get frightened. So this is going to come in the short. This is the lightest wearable artificial kidney. So future is bright. Xenotransplant is going to happen. So what scientific fiction is going to be a scientific proof. This just to show that how we donate the body. My previous speaker was talking about it. I myself have donated my body to anatomy theater of the college where I studied. That is the document has been handed over. It has to be duly legally filled up by a magistrate, and then it has to be registered in the anatomy theater, and then you have to hand it over. It has to be countersigned by your next kith. My son has signed as a witness, and this is how you do. And I hope many people will in the future will be willing to do this than to bury it. So another very interesting news is there is one urologist called Atala. He is in Wake Forest University in US. He is making artificial kidney out of these cells from our own body through regenerative medicine. Is attempting to make a kidney for us. So it's all bright for us in time to come. So with that good note, I finish my talk. Rajesh and then IMA office bearers for the opportunity. If there's any question, I'll be happy to answer.
We will have the question session shortly, sir.
Okay.
Thank you, Dr.
I'm
Ramalingam,
halfway
sir.
through in a surgery, Rajesh. But if there's any question, I will answer through the mobile inside the OR. Or my colleague, Dr. Sendil, who is equally competent, he will be answering. So both of
Yes,
us
sir.
will be
Okay.
listening to the question and answers whenever need. Please pass on the question to Dr. Sendil, and we will answer. Thank you,
I ask
Rajesh.
Sendil to join, sir.
Sir, excuse
Okay,
me.
Sendil is already sitting with me.
Sir, excuse me, sir. Professor Dr. Ramalingam, sir.
Yeah.
Sir, thank you so much for donating your body, sir. As an anatomist, I thank you very much, sir. Thanks for donating.
Welcome. I'm indebted to my college. So what better thing I can do? That's what made me to donate the body.
Sir, have you registered, sir? Have you registered, sir?
Long ago. I think about 8 years ago I registered.
Thank you so much, sir.
Welcome.
Now, it was a nice discussion about the recent advances, what are all happening. From the urologist side, we have seen that the robotic transplant and all those things, sir was explaining. That was very nice. Regarding this kidney donations, Dr. Saranan was telling about all the things, what is happening from the Ooty, they have transplanted the thing, and then regarding the perfusion also, he has told about the newer thing. And regarding the eye donation, the Dr. Chandy has given a brief idea about regarding how to take the eyes from the MLC cases also. And Dr. Rajasamukh Krishnan has told about the skin donation also. So overall, it was an exhaustive recent advances meeting about the organ donation and the body donation. I thank all the speakers for giving a nice lecture and good eye opening for all our IMA members. Thank you, one and all.